for this session. The webinar, I'm just going to click cancel on transcript. There we go. Fabulous. So the webinar session is scheduled for a slot of an hour. So I appreciate everybody's had a busy day, and it's that time of the day where we're all starting to feel a little bit sleepy and just want to put our feet up on the sofa. So the session may last an hour. It may last slightly less than an hour. So we'll see how it goes. But thank you very much for joining me tonight for the session on the heart. For those that don't know me, I'm Martin. I am the CFR trainer for North Wales, who work alongside John in Central and West, John Johnson, and Nikki Anderson, our South and East trainer. I joined the team in August of last year. So I think we've got quite a few people who have joined us this evening, which is really lovely to see. I hope you enjoy the presentation. Hopefully it's a lot of the information is nice to know, but there'll be some of the information on tonight's session that will be a good refresher for everybody as CFRs, and hopefully you'll enjoy it. So tonight's first slide, as you can see there, is our generic slide. So hopefully you've just taken a few minutes or a few moments just to have a read through the slide there. Just to quickly talk through it. Again, we've got a lot of people this evening, so it's probably might be better for not everybody to turn their cameras on. But if you want to turn your camera on, that would be absolutely lovely. If you just click, hover over the camera sign and click, and it'll activate the camera on or off. Also, just move along the chat bar there. You can see that the microphone symbol, karaoke microphone, whatever you like. If you hover over that, click it, it will mute. If you click it, it will unmute the microphone. During the session, if I could just ask you to keep that on mute, please, that would be fantastic. There will be a question opportunity at the end of the presentation. If you have a question throughout the presentation, by all means, you can raise a virtual hand. And again, that on the top bar is the symbol of a smiley face and a hand up alongside the face. If you just hover over that, it should bring up a few options, and the virtual hand is the hand directly below that icon. Click on that and the virtual hand will pop up. So moving to the right, again, chat bar, you can see the icon on the top bar there, which is a speech bubble. We'll be using chat bar this evening as well during the session, so if you could click on the bubble, the speech bubble, just to open your chat bar, and it'll appear on the right hand side of your screen. And I can already see that people have been chatting on that chat bar, which is really lovely to see. And it's nice to see we've got a wide spread of CFRs joining us across Wales this evening. And yeah, thanks again for your time. Just again, some of the generic slides at the beginning. These are West's values and behaviours. Just noticed. Excuse me a second. There we go. My notes have disappeared. So again, these are West's values and behaviours. And these will form part of our learner agreement this evening as we move through the session. And again, it's just to remind that we be kind to one another, care and compassionate. We will ask and listen. We'll be open and honest with what we say, trying to be our best as we possibly can, owning our decisions, and together we can be better. So the aim of tonight's session is to increase confidence in your clinical scope of practice and your self-confidence to discharge your duties as a community first responder on behalf of the Welsh Ambulance Trust. And by the end of tonight's session, hopefully you will have refreshed or gained a basic understanding of the functioning and the structure of the heart, refresher understanding of stable angina and acute coronary syndrome, known as ACS, recognise how signs and symptoms of stable angina and acute coronary syndrome may differ, and know then how to manage a cardiac emergency utilising our good old faithful CABCD approach. And I think it's worth mentioning, just before we continue, the reason why I've chosen the heart this evening in the webinar is because all throughout my career in the ambulance service, almost, I must say, every other call, but very often during a shift, a lot of those calls would be to a cardiac emergency, so involving the heart. And it's almost like the bread and butter call outs. And no matter what problem you're being called out to, and as CFRs too, quite often it involves the heart. So it's always interested me, the organ, the heart. But at the same time, it's always terrified me as well, because it's an organ that switch it off and life ends. But the mechanics of that organ are something that has really fascinated me throughout my career. So that's why I've chosen the heart this evening to talk about with you. Okay, so a little bit of fun to begin with. This is my simple analogy of, I think, what the heart is and what it does. Well, shall we say? So I like to think of the heart, and I compare it very similarly to the household boiler. We've all got one sitting in the cupboard in the kitchen. It's the pump of the house, and it pumps warm water, hot water through the pipes to our radiators all throughout our homes. And as we can see here, my simple diagrams, diagram A and B, we've got the simple diagram of the household central heating system to the left, and a diagram of the heart and the cardiovascular system to the right. However, this is a boiler and not a heart. That is the heart. And that diagram bears no consequence to the rest of the session. But it's just an analogy that I've always had in my head, that the heart is the central pump of our body, in the same way as our household boiler is at keeping our house warm through those cold winter months. Okay, so location. The heart itself is a relatively small organ compared to the mighty function that it has when you think about it. And that's something that's always fascinated me. The heart and its vital function. We're sitting here breathing, we're taking part in this session this evening, and you switch the light off. By pressing a switch on the wall, the light goes off. Our heart is operating. If the heart stops, it switches us off. And that's just so fascinating, and again, terrifying at the same time. It's about the size of your clenched fist. Sorry, Gary, you've got a hand up. Can I come to you? Just unmute as well. Do you have a question, Gary? Your virtual hand is up. Gary Davis. You might need to unmute. Is that you, Gary? No question. Okay. Well, we'll come back to you, Gary, if you do have a question, or pop it into chat. So the heart is about the size of your clenched fist, and it lies within the mediastinum of our chest. And the mediastinum is the name of the cavity within our chest that the heart sits. If I could just ask you for 1 second, just clench your own fist. Plus I can see if you can all hear me and what I'm saying. Yeah, great, super. And hold it against your chest, just in the centre, slightly to the left, and just look down and look at your own fist there. Fantastic. And you can see everyone in the classroom doing it, apart from one person at the back. Okay, brilliant, well done, thank you. So holding that fist against your chest and just looking down, it gives you some sort of context of the size of that body organ and what it does for us, keeping us alive. So the mediastinum is this particular part in our chest cavity, and you can see by the diagram there, the mediastinum is a small cavity between the lungs, and it's also, sorry, just get my notes here. It lies beneath the sternum, which is, as we know, the chest bone, and also posteriorly at the back, above the vertebral column. So if I can just try and show that with the laser pen. So this is the heart here. Fine motor skills at use here, trying to operate the laser pen. So you can see the heart lying in the mediastinum here on this X-ray or this scan picture, and it sits between the sternum there on the top and the vertebral column here on the bottom. And that's really important for us as emergency responders, because these are important structures above and below the heart. Because when we perform external cardiac compressions, we're squishing the heart. Squishing is not a medical term, it's my term, but I think it's a great descriptor. We're squishing the heart between the sternum in front of the heart and the vertebral column at the back. That is what we're aiming to do. We're actually compressing that heart as we perform external chest compressions. We're mechanically emptying the heart and allowing the heart to refill again. And as we know, the recoil when we do chest compressions is just as important as the compression, because when we recoil from the chest, from a chest compression, we're allowing the heart chambers to refill with blood, and more on that a little bit later. So really important. Just trying to get rid of my laser pen now. There we go. Okay, so a group activity. Talk about the structure of the heart. So what I'd like you to do in the chat bar, Gary Davis has just come back to me. Sorry for putting my hand up. Okay, with a link on my smartphone, it's still on my PC. Okay, Gary, no problem. Hopefully you can still keep up with the presentation on your smartphone. Any problems, just again, pop something in chat there. But thanks, Gary, for updating. Okay, so in the chat bar, let's look at the diagram here on the screen, and we can see a few labels missing. So what I'd like you to do in the chat bar, if you can tell me what label 1 and 2 are pointing to, which parts of the heart are labels 1 and 2 pointing to? So number 1 and then number 2. Jackie, your virtual hand's up. Do you want to just unmute?
Don't have any chat bar on my
No chat bar. Okay, Jackie, no problem. Would you like to tell me then? Everyone's putting answers in the chat bar, which you can't see, Jackie.
Okay.
Would you like to tell me what label 1 and 2 is?
Right atrium, left atrium.
Right atrium and left atrium. Okay, brilliant. So right atrium, left atrium. So those are the upper chambers of the heart muscle. Okay, so yeah, moving down to labels 3 and 4. What are we looking at there? Labels 3 and 4. Everyone in the chat bar, perfect, excellent, all correct. So labels 3 and 4, ventricles. Okay, yep, absolutely. Right and left ventricles, fantastic. Brilliant. So there we can see the left ventricle and the right ventricle. Okay, so label 5. Let's see what label 5 is telling us. So again, answers in chat, or if you'd like to pop your virtual hand up. There might be lots of virtual hands going up, so I might just pick somebody. Anybody like to tell me where we think arrow 5 is? Yes, agree, struggling with this flipping bar. Okay. I forgot that message has disappeared now, so Ventricular septum. Yes, that's a septum. That's a septum part of the structure. Bundle of His. Oof, we're getting a little bit deeper there. I'm not going to go that deep this evening. But yeah, the septum of the heart. And label 6, just to finish off. Where's label 6 trying to point at? But sort of make out as the heart relaxes, the arrow touches the part of the heart. Jackie, I'm going to come to you. Just unmute, Jackie, if you want to hazard a guess, or tell me what it is.
Is it the pericardium?
Pericardium. It is actually pointing, in terms of the diagram, it's myocardium. So again, it's the myocardium. So again, Richard Lewis, yeah, myocardium. That's the myocardium part of the heart. And again, we're going to drill down on that very shortly. Okay, so brilliant, excellent. Just skip forward there. So the myocardium, as I say, is the key muscle of the heart, and that's responsible for that pumping action to pump that blood around the body. And as we know, the heart itself has its own blood supply via a group of coronary arteries, and these vessels provide oxygen and nutrients direct to that myocardium to enable it to function and keep healthy. Okay, so we also have on the diagram here in red atrioventricular valves, which we can see here in red. Let me just put my pointer on there. There we go. So the atrioventricular valves here. So obviously these valves go between the atria and ventricular chambers. So the atrioventricular valves are formed in a way to prevent the backward flow of blood, and they operate according to pressure in the heart chambers themselves. When the ventricular pressure is at its highest, then the valves close, preventing that blood flowing backwards into the arteries. And here we have a closer picture of those valves. Now, these atrioventricular valves have very delicate string-like. I'll just get the pointer back onto the screen. These are beautiful string-like cords underneath the valve, as you can see there on the picture, and they're attached at the base by little small muscles here called papillary muscles. They almost look like a kite, if you like, and those control the closing of the valve. So when the valves open, they open into the ventricles, and when the ventricles contract, the pressure inside the ventricles push up and drive up those valves to close the gap. And those papillary muscles then contract, which then pull on the cords, stopping the valve from inverting back up into the atria. So a bit similar, if you like, to holding kite strings in an open field with the wind blowing your kite. When you feel the gust of wind under the kite, your muscles contract in the arm to hold on to those kite strings to stop the kite from blowing away, in effect. So in a similar effect, that's almost like what those papillary muscles are doing. They contract to ensure that those the cords that are attached to the atrioventricular valves don't then invert up into the atria. So then we have semilunar cusp valves, which also prevent the backward flow of blood. And as we can see, they're commonly known as the aortic and pulmonary valves. So you can see on the diagram there, the other two red labels, the pulmonary valve and the aortic valve. And these operate when the ventricular muscle relaxes. So the lower ventricular pressure, those lower chambers. And they look a little bit different to the atrioventricular valves. So this little diagram here is showing a diagram of what these valves look like. So the valves open when the ventricular pressure is higher, in the ventricles than it is in the arteries of where the blood is then being pushed out to. So when they close, so these valves, and then they close. When the ventricles relax, they fall backwards, closing the gap. But the interesting thing about these valves is exactly what they're called, semilunar cusp valves. These cup-like aspects of the valve, almost like cups, as those valves close back and close the gap, the blood in the arteries then falls back and starts to run back towards the heart. So these cups here, these cusps, should I say, capture the blood as it runs back down the artery towards the ventricle and gather in the cups. And then as the ventricles contract again, they push open that valve, and the blood that's sitting in those cusps gets ejected back up into the arteries. So a really interesting mechanical aspect of those two very different constructed valves that have very, very important jobs. So let's talk a little bit more about the structure of the heart. So here we've got a snapshot of a piece of the heart muscle. So I'm just looking at the chat bar there. Okay. So here we've got a diagram of, as I say, the heart muscle, that myocardium that we were talking about before. Just looking at my notes here, the writing on the slides that I can see on my screen is very small. So here, as we can see, this myocardium. So remember back to that diagram we had before where label 6 pointed to the myocardium. So the heart wall itself is made up of this fibrous pericardium layer, this fibrous layer around the outer edge there. Now this fibrous outer sac surrounds and protects and helps keep the heart in position within that mediastinum cavity that we talked about before. And it actually prevents the heart from over distending. So when it's contracting and relaxing, that fibrous sac keeps the heart in position and stops it from overextending. And it has an outer parietal layer and an inner visceral layer, which encases the pericardial cavity. Now this is only, this cavity here, this blue line is a potential space, a potential cavity. So again, that allows smooth movement of the muscle as it contracts and relaxes. A little bit like the oil that the car engine requires to allow the parts to move smoothly and seamlessly. Well, this potential space here, this potential space, the blue line, is doing the same thing. It's allowing the heart muscle to move in and out smoothly. And then the myocardium itself, which is the actual muscle, the muscle layer of the heart, the bit that does a lot of the work. And this is an involuntary muscle, so we have no conscious control over this muscle whatsoever. This is the muscle part of the heart. And on the inner side, we've got that endocardium, a very smooth lining, and that's the inner lining of the heart, so the lining within those heart chambers. So again, answers in chat. Out of the two ventricles, which ventricle is the biggest and why? So we've got somebody saying the right is the biggest. Has to pump around the whole body. Left, greatest pressure. Left, thicker muscle. Left does more work. Left pushes oxygenated blood around the heart. Yes. Left, right. We've got left, right, left, right. Yeah. Okay. So the answer is the left. The left ventricle is the muscle around the left ventricle is thicker, because that left ventricle, if you think about it, and there's been a few people who have correctly answered this, that left ventricle, its main purpose is to force the blood out into that aorta, that big hose pipe width of a blood vessel that then takes that blood all the way down the core of the body and branching off, supplying blood to the rest of the body. So it is the left ventricle, and the muscle around that left ventricle is the thickest part, because that's obviously got to push and force blood out then through and around the body. So it's the left ventricle. And here is a diagram which is showing us the coronary arteries that supply this muscle, this myocardium layer, this muscle of the heart. These are the coronary arteries traversing around the myocardium, around the heart, supplying the heart muscle itself with oxygen and the nutrients it requires to be able to function as we require it and need it to do to sustain life. And I'm not going to go into the details of the coronary arteries in tonight's session, but that system, those coronary arteries, are what supply the heart muscle itself with the fuel it needs to work and operate effectively. And again, the heart is an incredible muscle, constantly functioning to provide essential fuel for the body to be able to operate and survive. And it's said that the heart beats around 100,000 times a day. Just think about that for a second. 100,000 times a day, and we're completely oblivious to that. And in context, that's about 60 to 100 beats per minute. And the heart is a critical muscle of the body. It keeps us alive. It's the pump of the cardiovascular system. And as somebody quite rightly said, it pumps oxygen-rich blood or oxygenated blood around the body through the cardiovascular system, the circulatory system, before returning that blood back to the heart to then to bring the blood back to the heart, which is then rich in carbon dioxide or deoxygenated blood, back into the right side of the heart, and then pumped through to the lungs to reoxygenate and get rid of the carbon dioxide that it's just picked up, as shown here in the illustration on the screen. So it's a muscle, so fitness or lack of it can affect how effectively it performs through our lifetime. And as we can see, in general, the heart rate slows as you grow older, and with increased fitness, of course, as indicated here on this chart from the JAR calc, just showing you the different pulse rates through the ages as we mature. And in fact, is really interesting there at the bottom, the athletic adult, roughly on average between 40 and 60 beats a minute. So in fact, the fitter you become, actually, the slower your heart is likely to be, the heart rate. So a little bit more about the function. As I've already identified, the heart pumps blood around the body, and that's its primary function. It is via the blood that the important elements of life, such as oxygen, amino acids, proteins and glucose, are transported and delivered around the body. Now, the pump action of the heart is controlled via a very complex electrical impulse system, which I'm not going to go through in detail this evening. But very basically, when an impulse occurs within the myocardium, the very specialist group of cells within the myocardium, then the heart or parts of the heart contract. And when no impulse occurs, the myocardium relaxes. And we feel this as the patient's pulse when we feel for a pulse at the radial, for a radial pulse or a carotid pulse. And what we feel is the heart contracting and relaxing. And this is known as the cardiac cycle. And as we can see here, the cardiac cycle is broken down into 3 stages. So we can see the atrial systole. That's the name given to the contraction of the atria. A ventricular systole is the second stage, and that's the contraction of the ventricles. And then the third stage of the cardiac cycle is the complete relaxation of the atria and ventricles. And we can sort of see that looking at that diagram, that working diagram here. So we've got the contracting atria, then the contracting ventricles, and then complete relaxation of all the chambers before it starts all over again. So very little bit, a small amount of information here about blood pressure, because as CFRs, we obviously were rolling out the enhanced skills this year, or so should I say we have been rolling them out, and blood pressure is a new skill for CFRs predominantly. So hopefully this very basic diagram will help demonstrate how the systole and diol stages of the cardiac cycle can relate to the blood pressure reading that we measure now as CFRs. So imagine the cylindrical shape, back to my laser pen, the cylindrical shape here is a blood vessel, and the red arrow is indicating the direction of blood. And here you can see black arrows, which are indicating the pressure or the direction of force that that blood passing through the vessel is exerting on the walls of the blood vessel. So when the heart contracts, when the ventricles contract and forces the blood out of the heart into the blood vessels, into those arteries, the pressure is at its greatest within those blood vessel walls. And as we can see, the black arrows in the systole phase of the cardiac cycle is at its greatest. It's pushing outwards, out towards the vessel walls. And that's where we get that reading. That's the top number when we record our blood pressure. As opposed to the diastole stage of the cardiac cycle. So again, the cylindrical shape here is the artery, blood passing through it, but the diastole stage here is when we have a decreased pressure within the blood vessel itself. So that's when that ventricle is relaxing. So the blood isn't being forced through the arteries. So it's exerting less pressure onto the wall of the vessel. And the diastolic reading is that bottom number of our blood pressure measurement. So we've got a higher pressure when the heart contracts and pushes the blood out. And then when the heart relaxes, then we have less pressure in the blood vessel walls. And that gives us our blood pressure. Okay, so just moving briefly on to, it's an overview really of two cardiac emergencies that as CFRs we might attend on a very regular basis. And I'm looking at stable angina and the acute coronary syndrome. Just sort my notes out here. So angina is a set of symptoms. Common symptom to this is chest pain associated with a reduced or lack of oxygen to the myocardium, caused by atherosclerosis, seen here in both pictures to varying degrees. So atherosclerosis, it occurs when there is a buildup of lipids in the blood, fat within the arteries, and it causes atherosclerosis. And that builds up and sticks to the artery walls, the inside of the artery walls, as we can see here in the picture to the left here. And that causes narrowing of the artery itself. And in the case of angina, that narrowing occurs in the coronary arteries. It's, as I've already discussed, those coronary arteries supply the heart muscle with blood and oxygen, supply it with the fuel it needs to function. So if we have this atherosclerosis building up in those coronary arteries, then the greater we exert ourselves, the more blood the heart requires to be able to beat faster. And if those arteries are narrowed due to atherosclerosis, it reduces the amount of fuel that the myocardium will receive during that exertion. And that then can produce chest pain. And we refer to this as coronary artery disease. So atherosclerosis building up over a number of years in those arteries, that's referred to as coronary artery disease, or CAD. And normally when those arteries are greater than 70% stenosis or narrowing, have narrowed by more than 70%, or at least of one coronary artery, this is when problems will start to occur, certainly as seen in angina. And typically with angina pain, it will occur on exertion when we want the heart to work faster, or with emotional stress, for example. But what tends to happen is when the patient rests, the heart starts to slow and doesn't require that huge demand, and the pain and the symptoms will tend to ease. So the workload on the heart is reduced. And we'd refer to this type of angina as quite stable angina. So pain will come on the patient exerting themselves. When they rest or use medications, the pain will ease. So that would be classed as stable angina. We would tend to refer to unstable angina when the pain does not ease when taking those measures, such as resting or using angina medication. And this will usually occur once that narrowing has become quite extensive. And then to the right, acute coronary syndrome, or ACS for short. This is a term used to describe three very dangerous cardiac conditions linked to a sudden or an acute reduced blood flow to the heart muscle, leading to an immediate cardiac emergency. And this is what we would find in somebody having a heart attack, or known as a myocardial infarction. And again, to diagnose a myocardial infarction, you would need access to an ECG machine to be able to monitor the heart pattern. Unstable angina is also classed as one of those dangerous conditions of acute coronary syndrome, because the narrowing has become so extensive that it can create and cause this acute blocking of the artery. And these sudden blockages in acute coronary syndrome can be caused by embolisms. And an embolism is a foreign body which blocks an artery. And you can get blood embolisms, you can get fat embolisms, where fatty particles are released, sometimes following long bone fractures or severe burns. They sometimes become released into the bloodstream. Air embolisms, so changing air pressure, for example, the diving or with bends. And cholesterol embolisms. And that's when small pieces of atherosclerosis may break away in the artery and float around in the circulatory system and then become lodged in a coronary artery, blocking that artery. So the acute coronary syndrome is that sudden and acute blocking of an artery, suddenly reducing the amount of oxygen the heart muscle is receiving, compared to stable angina, where that narrowing restricts the blood and oxygen supply to the myocardium. But when you rest or take medications, the pain will ease. Okay, so a group activity. What I'd like you to do in chat, I'd like you to list or describe how might the presentation of stable angina differ from that of an acute coronary syndrome event. So the signs and symptoms first of angina or stable angina. So if you could list in chat, how might you consider the presentation of chest pains in a patient to be stable angina? Relieved with rest. Excellent. Somebody's been listening. Pain in the chest? Yes, quite possibly. Angina, pain on exertion, left-sided pain. Pain likely related to exercise, pain in the left arm. Stable angina eases with rest and reassurance medication. Breathlessness, yes, may radiate with rest. Pain often across the chest, relieved with medication. Pain, right, okay. Yeah, some great answers there. So in terms of stable angina, we might find that the pain or that discomfort is felt across the chest, and often described sometimes as tightness or as indigestion-like aching in the chest. It can radiate to the arms, to the neck, to the back, or to the epigastrium region, which is the bit between your belly button and the chest. Exertional shortness of breath. So as somebody quite correctly said there, the pain or shortness of breath, it might just present as shortness of breath, not necessarily with pain, might come on with exertion, and again relieved with rest or GTN medications. Okay, so what I'd like you to do now is maybe list a few more ideas to how you think an acute coronary syndrome might present with a patient. What sort of differences might you think when you're dealing with a patient with chest pain that might make you consider this is an acute coronary syndrome event as opposed to a stable angina event? Impending doom. Someone's been reading the book. Yeah, absolutely. Feeling of impending doom, sweaty, grey colour, chest tightness, sweating, severe sweating, pain lasts longer. Pain does not ease or worsen, doesn't go away with rest, clammy chest pain, severe pain, sudden onset with exercise. Yeah, absolutely. Nausea. Yeah, this is quite severe. This is really not going away. Continual pain. There's some great answers there. Great answers. So again, acute coronary syndrome, we're looking at this as being, it's not relieved, is it? It's substernal chest pain, central chest pain, which can radiate too, often described as a heaviness, a squeezing or a crushing or tightness, greater than 15 minutes and unrelieved by GTN. So if you've got somebody you're attending to who suffers with angina and they've taken their GTN spray and the pain is still intensive after 15 minutes and it's not been relieved, then naturally you might be then starting to think this could be an acute coronary syndrome. It could be a heart attack. It could be unstable angina, but it could be that acute blockage of an artery as opposed to the angina. Nausea, vomiting, somebody had mentioned, pain, clammy, lots of sweating, shortness of breath, feeling of that impending doom. Okay, so we're moving on now to a case study of Alan. So this is a group activity. We're moving in now to that patient assessment. How would you manage somebody with chest pain? So this is a case study of Alan. You are a community first responder and it's 2 o'clock on a Saturday afternoon and you have been mobilised to a 999 call in your town. Alan is 65 years of age and he's just arrived home after visiting the newsagents down the road to buy some cigarettes. Now he's complaining of pain across the chest when he gets home, and when he talks he struggles to complete sentences. His skin is pale and appears clammy. He's standing up, leaning against the door when you arrive, rubbing his chest. Now, what are you going to do? Now, following your structured approach to patient assessment, what are you going to do first for that primary survey? So think of primary survey first. Sitting down, put him at rest if possible. Great, Eddie. Tell him to get a delivery, did somebody say? Yeah, maybe not quite at that point. Sit him down, the history. What's this primary survey about? What's the point of a primary survey? Think of the primary survey. So there, actually sit him down, reassuring, obs, history, primary survey. What's the purpose of a check pulse? Right, Ewan, you're on track. You're on track. Think of your primary survey. Check ABCD. Set breathing, heart rate, pain. Okay. ABCDE. Communicate as you check breathing rate, breathing. So is he breathing? These are the things that you need to know in those very first few seconds. Primary survey, airway, breathing. Yes. SATs. Okay. Yeah. Okay. So remember, Is it safe for you? The primary survey, first consideration, is it safe for you to enter Alan's house? Danger, safety. Your safety is your first consideration. Response, AVPU. Is he alert? Does he respond to your voice? Does he respond to a bit of painful stimulus, so shaking the shoulder or just squeezing the trapezium on the shoulder? Or is he unresponsive? He's standing up, leaning against the door. Somebody said sitting down. Fantastic, brilliant. Again, you're thinking of that CABCD approach. We're looking at this stage. This is the primary survey. Those first 60 seconds of a general impression. Do I need to do something very urgently before I move on any further? Safe approach, check response, reassure, ask him to sit down, check it. Yes, fantastic. So that's CABC. Certainly in the primary survey, we're checking for catastrophic hemorrhage first, airway, breathing, circulation. Do we need to do something at any of those points before we move on to more detailed and more time-consuming elements of our patient assessment? And correct the major ABC problems first. Okay, so now we've done that 60-second general impression. We've sat Alan down on his sofa. We've put him at rest. He's breathing. His airway's okay because he was standing up and he was trying to talk. So we know his airway's okay. He is breathing. He might be struggling with his breathing. Somebody mentioned a SAT Pro. Fantastic. So we're immediately assessing the effectiveness of that breathing, because that's going to be your evidence to consider oxygen therapy or not. So secondary survey, patient survey, secondary survey. Now what are we looking at with the secondary survey? We're going now into more detail. Somebody has already, a lot of these answers have already been put into chat, but let's look at it in that step-by-step approach. Sample, check history, medications taken, Socrates, fantastic. Blood pressure, Ewan, fantastic. Yes. History, medications. So now we're spending a little bit more time, again, a little bit more detail, because we've initially sat Alan down, we've put him at rest. We know it's safe for us to be there. His airway's open, he's breathing, his heart's beating. Obtain BP, sample Socrates, fantastic. So again, we can tailor it to the situation that we're in. Gain history. So you've already put sample there. Socrates, which is your pain assessment score, fantastic. I'm not going to ask you to list what sample or Socrates mean unless somebody is really quick on the keyboard and wants to stick it in chat. Vital signs. So this is now when we're drilling down. We're spending a little bit more time now. Now we'll check and count the breathing rate. Now we'll check and count the pulse rate. Now we can put the cuff on the arm and take a blood pressure. And again, we're going to reevaluate the oxygen therapy if we've started it, because we've got that probe on the finger, and we can reduce, adjust, or remove the oxygen, or depending on what that pulse oximeter is telling us. And this is really important because this all feeds into our ability to formulate a news score. So that national early warning score, really critical clinical information that allows us to gauge how unwell they are, but also to pass that information on potentially to a clinician over the other end of the phone. It allows the clinician to paint that picture whilst they're sitting in the control room miles away. Really important. Don't forget, reassess, reassess, reassess. So every 20 minutes or so, you're going to reassess whilst you're waiting for that backup to arrive. Also remember, update the control room and the clinical desk. Once you've got that clinical data, you've built that clinical picture of Alan, complete the documentation and prepare for that handover to EMS when they arrive, using the @MIST mnemonic, which you may remember from our CPD Part A. Age, time, mechanism, injury. I've completely lost it myself now. Who wants to remind me? @MIST in the chat bar. @MIST, anybody? Time of onset. Correct. Thank you very much. Yes, thank you very much. to those who have contributed there to chat. Be prepared to resuscitate. With somebody like Alan in that emergency, you've always got to be prepared for that moment where Alan becomes unresponsive, and then you have to start resuscitating. So again, always be prepared to resuscitate. And you'll be glad to know that because of your excellent professional response and your attention to detail and brilliant treatment, Alan was back into the community supporting his local before the end of the week. So well done to your assessment and treatment of Alan. Okay, so we are coming to the end of tonight's session. A little bit of a whistle-stop tour. It's a presentation I put together. I only ran through it again earlier on today. I hope it's been informative or a refresher for you, but hopefully you should now be able to identify some of the basic functions and structures of the heart, understand the difference between stable angina and acute coronary syndrome, recognise the differing presentations of stable angina and acute coronary syndrome, and to formulate your CABCD assessment of a patient presenting with a cardiac medical emergency. And thank you for helping me out with that mist at the end, which completely had a brain fog moment. So thank you very much. Any questions about what I have discussed tonight in the presentation? I can see a hand there. I've got Paul Wiggins. I can see he's popped up on the screen. Paul?
Hi Martin, thank you very much for tonight's session. Just
Paul.
a very quick question about aspirin.
Okay.
Would our patient just then have been advised to take any aspirin by the call handler when they get that call? And if they haven't, but subsequently aspirin becomes available, are they still permitted to take it with us being around, or what's the situation?
In terms of aspirin, usually the advice given from CCC, certainly with chest pains, that they will ask if aspirin is available, and they would have been given that instruction if it was available to administer 300 milligrams of aspirin. As a CFR, I would say liaise with the clinical desk first if that instruction hadn't been given or discussed with CCC first. I would advise liaising with a clinician over the phone first, but generally there is a discussion with chest pain patients from the CCC regarding administering aspirin. As a CFR, I would advise, if that conversation hasn't taken place over the phone, to liaise with a clinician first over the telephone on clinical desk.
Thank you. That was what I was hoping you were going to say, so thank you.
Liaise with the clinician. Thanks, Paul. David, was that David or Paul? I've got David with a virtual hand up. I just need to unmute, Dave.
Just wondering how you spot the difference with pericarditis.
Pericarditis. You're unlikely to be able to distinguish what's causing discomfort. Sometimes with pericarditis, the pain might be relieved if someone with chest pains while sitting down leans forward. But again, that's not hard and fast rule. In a situation where you're managing someone with chest pain, a chest pain presentation, then you're managing somebody with chest pains. It's very unlikely that you'd be able to differentiate between what is causing that pain, as is the situation with any emergency that you're dealing with as CFRs or as an EMS responder. You know, quite a lot of the time you don't know what's causing the problem. You're just treating what you see and what you find, a bit like the catchphrase program, you know, say what you see, but we're treating what we see. But yeah, without an ECG as well, you wouldn't be able really to differentiate between stable angina, acute coronary syndrome, pericarditis causing that pain. Quite often with pericarditis as well, the patient may have a temperature because you've got some infection there, possibly, but very difficult as a first responder, EMS or CFR to differentiate. You're just dealing with somebody who has chest pains. Well, thanks for the question, Dave. Any more questions? Let's go back to chat just in case. Okay, so if there are no more questions, I will quickly go to the next slide. Oh, well, my slides have disappeared. I don't know why my slide has disappeared. My presentation has disappeared off the screen. It's coming back on. IT glitch right at the end. There we go. So again, as we end all our sessions online, it's really important to say thank you, obviously, for your time this evening. Appreciate your time is important. It's 5 to 8 now. Just as a reminder, a well-being checklist. It's really important in your work as a CFR and in life in general. Reflect on what went well today. Recognise what was difficult. It's important to check in with your colleagues and peers as CFRs. Just check in sometimes, make sure everyone's okay. And important to take that moment to reflect as well, and think about what difference you've made to people in your community. You're doing such an admirable role as community first responders, full of immense respect of what you do as volunteers. Ask yourself, are you okay? It's really important to be kind to yourself. If things aren't okay, please reach out, please talk to us. There's lots of support available to you within WAST as you are a community first responder. It's really important that you reach out. So again, look after yourself, but thank you for this evening. My slides have completely gone amiss now. I'm going to leave it there because there's something IT-ish going on with my laptop. So I'm going to end the session there. I'd like to thank you once again for your time this evening, and I shall close the session. But thank you very much for your time.